Hi, epiglottis is a part of larynx or the voice box. So, to start with, I'll tell you the different parts of larynx and how it works so that you get a better understanding about this condition. This is the larynx. This is the inside view of larynx. And the structure you see, this one is the epiglottis. This this one. So when we breathe in, this epiglottis, like a lid, it is open, air goes in between the vocal cords into the trachea to reach the lungs. When you eat or drink something, this epiglottis, it protects the airway by closing the inlet of the larynx and allows the food to pass over it to enter the esophagus, which is seen, the food pipe which is seen behind the trachea. That's how the epiglottis works. Now, the infection of the epiglottis, this one is called as epiglottitis. That doesn't mean that only the epiglottis will be infected. Actually, the epiglottis, aryepiglottic fold, valleculae, all the structures are nearby and the mucosa is in continuity. So, when you have epiglottis, you have involvement of the surrounding structures also. So, acute epiglottis means infection or inflammatory condition which involves the upper part, that is those structures above the vocal cord, mainly the epiglottis. And the age group, the children are more involved, especially between the age group of 2 and 6. There are so many causes for epiglottitis. The bacterial causes are, the most common one is Haemophilus influenza type B. Nowadays, in the vaccination schedule, we have vaccine for this. So, the Haemophilus influenza infection as such, it's on the decline. Now, the commonest cause for acute epiglottitis is group A streptococcus. So, bacterial infection is the commonest cause for this. You have epiglottis due to virus infection or fungal infection also, can be because of thermal damage or chemical damage or sports injury or foreign body. But here I am going to tell you mainly about the bacterial infection, acute epiglottitis. Now, the child to start with will have running nose and mild fever, and there is a sudden transformation within a very short time into a desperately ill child. And he starts developing high fever, 102 and 103, severe sore throat, he is not able to talk, and he develops breathing difficulty too. Please rush to the hospital at the earliest. This is a medical emergency. And when you reach the hospital, when the duty doctor has a look, the child will be having an anxious look and he will not be moving much. He will be restless, but he will not be moving much. Restricted mobility and high fever, 102, 103. Heart rate is very high, 110, and respiratory rate is more than 40, more than 30 to 40. And the position of the child will be like this. If you ask the child in the casualty to lie down, he will refuse. The child will be sitting up, sitting in the mother's lap, trying to look upwards, the neck extended, and the body, the shoulders facing forwards, leaning forwards, mouth open, breathing to the mouth, and tongue protruding out, saliva drooling, because even the saliva he is not able to take in, because that will result in severe pain. That's why. And he will have breathing difficulty, stridor, which you call it stridor. And the particular position, how he is sitting, like both the hands forward and leaning forwards, we call it tripod sign, or the sniffing air position. Now, this very look is enough for the doctor to diagnose as a case of acute epiglottitis. So, what is he going to do? He is going to shift the child along with the mother to the ICU. He will not touch the child. He will not examine the child. He will not put in an IV cannula. When he reaches ICU, he'll start with oxygen. He'll give the oxygen mask to the mother and he will hold the oxygen mask as near to the child as possible. And just wait, I'll be back at the earliest. And what he'll do, he'll inform the ENT specialist and anesthetist at the earliest, and he'll tell them it's a dire emergency, please come at the earliest. Urgent means come immediately. Emergency means as soon as you get the call, you be in the hospital. So when the ENT specialist and anesthetist reach the hospital, they rush to the operation theatre, get the emergency tray ready and the endoscopy too, and they shift the child immediately to the operation theatre. When the child reaches the OT, the anesthetist, he'll start with slow inhalation anesthesia, and the ENT surgeon will do a laryngoscopy and examine the throat to have a look of the epiglottis to confirm the diagnosis. This is a picture of a normal epiglottis, and this is a video of a child suffering from epiglottitis. See, this is a red structure. What you see, the swollen structure is the epiglottis. See the difference between this one, and here there is no space for the air to go in. So once the diagnosis is done, the ENT doctor will take a throat swab for culture sensitivity to know which bacteria, and to know the which antibiotic has to be given for that. And once that is done, the anesthetist will take over. He will intubate the child, and the ENT will be around in case we need to do a tracheostomy. Once the tube is in place, the air is secure, then the child is safe. At this time, we'll go ahead and take an X-ray to reconfirm that we already have a diagnosis. For a documentation, reinformation, we need to take an X-ray also, where you can see the epiglottis is swollen and the airway is very less, and the epiglottis, this one is called as a thumb sign. Some doctors, suppose it is mild, they will prefer to take an X-ray before the ENT surgeon comes. But this is what we do. Once the child is intubated, at the same time, when we know that the airway is going to be secured, the staff nurse will put in an IV cannula, draw in blood for examination and for blood culture. And start with third generation cephalosporin antibiotics, steroids and paracetamol. Once that is done, we'll put a nasogastric tube also, because the child is going to be intubated for 2-3 days and he's going to be in ICU, and just IV fluids alone will not help. So to give food, we have to insert a nasogastric tube too. So the child will be in intensive care unit for next 2-3 days, and every day we will check blood to see whether the blood count is coming down. Usually it comes down by 2nd or 3rd day. So every day the anesthetist will have a look, and the ENT surgeon also will have a look to see whether the epiglottic swelling has come down or not. And that time we'll receive the blood throat swab culture report also. So if you want, we can add up one more antibiotic if necessary. And once the total count starts coming down and the epiglottis swelling has come down as per the laryngoscopic finding, and the anesthetist says there is air leak around the tube, it is safe to remove the tube. On the 2nd or 3rd day, the tube will be removed, which is called as extubation, and child will be observed in ICU that particular day, and next day morning he will be shifted to normal room. And the subsequent day he can be discharged. And I told you in the very start, this is a medical emergency. You have to rush to the hospital at the earliest. If you delay, then there will be airway obstruction, there will be respiratory failure, then I don't have to tell you next. Hope you understand. In mild cases, they can spread to result in pneumonia or brain fever or meningitis, or meanwhile the child can develop hypoxic brain damage too. So this is a medical emergency, and you have to rush to the hospital and be calm that once the airway is secure, child is going to be normal. So the 4th day, 5th day, the child will be discharged. The next 5 days, you need to take care of the child, and you will be given few medicines for next 5 days. And for those at home, the child, we have to give vaccination against Haemophilus influenza. And in case of adults, you have to take, as a prophylactic, they have to take rifampicin. So that's how we manage a case of acute epiglottitis. Thank you so much.